Hello everyone, this is Craig Fitch with Oculus. Welcome to another Oculus webinar. We certainly thank you for attending this webinar titled Advanced Technology Applications in Anterior Segment Diagnostic and Management Utilizing the Oculus Pentacam Tomograph. Our speaker is Dr. Barry Eiden. Dr. Eiden is President and Medical Director of North Suburban Vision Consultants Limited, a private group practice specializing in primary eye care, complex contact lens management, treatment of eye disease, and refractive surgery. He is President and Medical Director of the National Keratoconus Institute and Organization, providing patient care and practitioner education in the field of keratoconus and corneal ectasia. Dr. Eiden is also co-founder and president of iVis Eye and Vision Research Institute, which is dedicated to clinical research and development of technologies in eye care field. Dr. Eiden is the Assistant Clinical Professor at the University of Illinois at Chicago Medical Center in the Department of Ophthalmology, Corneal and Contact Lens Service, and an adjunct faculty member of the Indiana, Illinois, Salis and UMSL Colleges of Optometry. Dr. Eiden is past chair of the American Optometric Association, Contact Lens and Corneal Section. He is a fellow of the American Academy of Optometry. Dr. Eiden is a research consultant for numerous contact lens technology and pharmaceutical companies and lectures extensively both nationally and internationally. Ladies and gentlemen, if you have any questions throughout the webinar, please use the screen on the right-hand side and type in your questions, and we will have some time at the end of the webinar to answer those questions. So without further ado, please welcome Dr. Barry Eiden.
Well, thank you, Craig, and good evening, everybody. It's wonderful to once again speak on behalf of Oculus in terms of these webinars. I think they're really useful, and I've gotten a lot of positive feedback on those that I've done before, and hopefully tonight will be no exception. Tonight we're going to speak about a topic that is really close to my heart. It's about a technology that I actually am quite passionate about, and that is Pentacam tomography. We've had the Pentacam system at our practice for a number of years, and I have to be honest in saying that I don't think any other technology do I use more significantly, more frequently than Pentacam in the practice in so many different ways. I wanted to just share with you some of my disclosures in terms of consulting and so on and so forth, and we'll kind of get right into the topic this evening. And in order to start out and talk about Pentacam, I think we have to take a step backwards a little bit and go back to a technology that probably a significantly larger majority of individuals are utilizing in their practice, and that is corneal topography. So we'll talk about some differences between traditional Placido-based corneal topography and elevation-based corneal tomography, such as Pentacam. So what is topography? Well, if we wanted to use sort of a dictionary definition, topography is a detailed representation or description of the surface characteristics of a structure. So we have map topographies and so on and so forth. However, when we're speaking about the eyes and we're talking about corneal topography, we really are referring for the most part to what is termed Placido-based topography or video keratoscopy. And what Placido-based topography really is, as most of you know, is reflecting concentric rings onto the corneal surface. And a computer analyzes the separation of the rings, and the greater the separation at any particular point along the surface of the cornea, then the flatter the radius of curvature is. And the less the separation, or the closer together the rings are, the steeper the radius of curvature would be. Now, what we're really measuring with Placido-based topography is curvature itself. It's a curvature-based system. And we're getting really excellent localized measures of corneal curvature. It's very sensitive for that. However, there are limitations. And there are things that clinically we'd have to admit are kind of missing when we're doing Placido topography. So let's kind of go over those and see what pieces might be missing that could be important to us clinically. And probably number one on the list from my perspective is the fact that there's no analysis of the back surface of the cornea, the posterior surface of the cornea, when we're performing Placido topography. There's no representation of corneal thickness in the cornea as well when we're doing Placido-based topography. And we actually are not directly measuring the central cornea when we do Placido topography. And I indicated here, smile for the camera. What I meant by that is straight in the center of the rings is where the camera, the video camera, is for Placido-based topography. So that central area is actually missing data. The instrument does not measure that, and it just has to make assumptions from its surrounding data about what probably is going on in the apical portion or the central portion of that cornea. And as most of us know who've utilized Placido topography over the years, when we have corneal surfaces that are highly irregular, that's when so much information starts to drop out in Placido topographies. And in essence, when we need it the most, it's not there for us. Whereas we'll see even the most irregular surfaces, and I'll show you some fairly amazingly irregular surfaces later on, these surfaces can be measured with tomography and with Pentacam. Another limitation with Placido topography is the area of the cornea that can be actually measured. Maximally about 9 millimeters, and it averages maybe about 6 to 7 millimeters. Now, I have to say that there are some systems now being developed that are taking sequential images or Placido-based images and decentering those images so that, in essence, they can put that data together from multiple images to cover more of the cornea. But you'll see so much greater corneal coverage with Pentacam analysis. Now, one important concept to keep in mind is that measurements of curvature in and of themselves have limitations, whether they're derived from Placido-based systems or even elevation-based systems. When we're looking at curvature measurements, we're not measuring unique aspects. In other words, these measurements are reference-based, and that reference is from the camera itself to the center of the reflected rings in Placido, or to the center of that corneal surface. So we'll see in a moment that if patients have larger than average angle kappas, we can have artifacts that are created that can throw us off clinically from time to time, and we'll see examples of that as well. And here we can see an example where we have a corneal surface radius, which is the same between those two surfaces. But the difference is the fact that one has a 0 angle kappa, and the line between the center of the cornea and the camera and the center of the cornea and the macula, so to speak, or the foveal center, are coincident. So you have a nice straight line. We have the same curved cornea, but we have on the right an example of a large angle kappa where the line of sight is off-center. And what happens, as I'll show you in a second, is we actually create a false positive for keratoconus, or a pseudo-keratoconus, when they don't line up and we have larger angle kappas, and that's what we're going to see right now. Same cornea, same curvature, but we can see one with a large angle kappa, one with a 0 angle kappa. A truly regular symmetric bow tie astigmatism will look on curvature like they are keratoconic, or inferior steepening. Now, if we were able to change that line of sight on the right side to get it to center up, it would change in terms of the map that would come up on the sagittal or axial curvature map, and it would look regular like the one on the left. So you can get a false positive for keratoconus on patients who have large angle kappas, as I'm showing you, as a limitation of Placido, and actually a limitation of all curvature-based measurements. So now we're going to move on to corneal or anterior segment tomography. And what do we mean by tomography? A tomograph, it's a two-dimensional image or a slice or section through a three-dimensional object. As we can see, CT scans are the most common example of that. And here, in doing anterior segment tomography, we're taking two-dimensional slices through the anterior segment. And because the Pentacam takes multiple images on a rotating basis, we end up getting a full coverage of the anterior segment 360 degrees around, and we can reconstruct that three-dimensional object. I tend to refer to Pentacam as a topographer on steroids, and the reason is that it can do just so many things and go way beyond what we've come to expect from our traditional topographers. And this is just a list of many of the things that we'll talk about tonight as we go along. So the imaging on Pentacam is based on a principle called Scheimpflug Imaging. And we don't need to go through the details of how a Scheimpflug image is created, but it suffices to say that the end result is that we increase the depth of focus. As you can see the difference between the photograph on the left and the photograph on the right, we have a greater depth of focus. So when the Scheimpflug image of the anterior segment is taken, we can get a clearer image of the cornea, go all the way back into the anterior chamber, to the iris, and even into the anterior portion of the lens, as we'll see through some imaging in just a few moments. Now the Pentacam itself takes these slices, these two-dimensional slice images, with 50 scans that are taken in 2 seconds, covering 360 degrees. The standard Pentacam has 3.6 degrees of separation and creates 25,000 true elevation points. Now, there is a version of Pentacam called the HR for higher resolution, and that takes twice the number of scans in the same period of time, and that results, as you would expect, in a higher resolution image. So there's the Pentacam standard, and then there's the HR version, which produces, again, a higher resolution image when you're looking at the Scheimpflug imaging. Now, the clinical implications, the clinical uses of Pentacam are extremely diverse. And probably the most common and frequent use for us in practice is in corneal analysis, looking at corneal shape, thickness, and imaging the cornea itself. But it also has tremendous utilization in glaucoma diagnostics. We can, through the use of the pachymetry aspects of Pentacam, relate the corneal thickness to the IOP. We have excellent imaging of the anterior chamber and quantified measurements of anterior chamber depth and volume and angle measurements, as we'll see later on in the talk. We can do cataract analysis through what we call densitometry, which is a way to quantify the density of the opacity, and we can monitor that over time. And then through a variety of software applications, IOL planning, and other surgical plans such as corneal ring segments like Intex and others can be utilized. And today, with the advent of premium IOLs, multifocals, torics, and such, some of these calculations and utilization of Pentacam will go quite far in helping the surgeon plan out the surgery for optimal outcomes. So the Pentacam, what does it provide for us? Number one, true elevation of data of the anterior cornea, true elevation data of the posterior cornea, and we mentioned how important that is. Global corneal thickness or global pachymetry, thickness throughout the entire surface of the cornea. And it can give us curvature data, both axial and tangential, but this is based on true elevation data, and some folks do feel that it actually is a more accurate method to even determine curvature values versus direct curvature measurements. So here is an example of what's called the 4-map refractive display, the most commonly used display. And most of the time we're going to see these 4 maps, and we select what's in there, but typically what you're going to see, and most often placed as we have it here in the upper left hand, the actual axial or sagittal curvature map, upper right hand being anterior corneal surface elevation, lower right corner being posterior corneal elevation map, and lower left corner corneal thickness map, global corneal thickness map, or global pachymetry map. Now, we can move around these, and you'll see some slides where they're not in exactly this position, but this is sort of the standard positioning that most of us use in clinical practice. A really interesting and I think useful new display is called the Indices display. And with the Indices display, there's numerous types of measurements that we find important clinically that are displayed. And there will be distributions of normal and abnormal distributions, as you can see in those curves. And for each of the measures, you will see also where this particular patient's findings are. And if they're in the normal or mean area, if they're 1.5 standard deviations from the mean or outside of 2.5 standard deviations. As you can see here in the anterior chamber angle, this particular patient has a relatively narrow anterior chamber angle, and we can see it's outside the 2.5 standard deviation from the mean in normative data. and we could also see the distribution of the normal and abnormal groups, and we can see where the patient actually falls through that little line. So it's really a wonderful way to get a summary of really key findings, find out where you are for that particular patient in that particular finding. Now, if you want to go to the specific maps, you can then go ahead and go up to this area and, for example, select your 4-map refractive or any other key map that you want to select and go directly from the indices display directly to those particular displays. A really useful new software. Now, here we see, once again, a 4-map refractive. The location of the various displays in the 4-map are different than I showed you before, but what I wanted to show you here was the upper right being the axial or sagittal curvature. That kind of looks a little suspicious, doesn't it? If you see there's a difference between the superior and inferior curvature values with inferior steepening, and look at some of those numbers approaching 50 diopters, which would surely, if we were seeing this only through Placido-based topography, would make us very suspicious that we're dealing with keratoconus in this particular case. However, with the elevation data of the front and back of the cornea, which you can see inferiorly, those two down there, we actually show that we're not dealing with ectasia. As you'll see in a few moments when we go over elevation data, that is representative of quite regular astigmatism, both matching up on the front and back surface of the cornea. And then let's take a look here at the global pachymetry map, and you can see a couple of things. One, we're dealing with a pretty darn thick cornea, and it's pretty atypical for any ectasia to have thickness of those values. And we can also see that the thinnest part of the cornea actually is centered, which, as we'll find out in a little bit, is atypical of most forms of ectasia. So let's kind of do a quick review of elevation and how we display that. Well, elevation has to be in reference to a reference shape. And in this particular case, and what we do here is we create what's called a best fit sphere. So the computer itself kind of looks over the elevation data of the entire surface, whether it's the anterior or posterior, and kind of creates an average or a best fit spherical surface. And what will happen is any particular point in elevation, either on the front or back of the cornea, will be indicated in color as being more anterior to the best fit sphere or more posterior to the best fit sphere, and it will be color coded accordingly. More warmer colors will be more anteriorly displaced, and cooler colors would be more posteriorly displaced. Now, you can use other reference shapes other than a sphere. For example, some people like to use an ellipse as a reference shape, and we know that most corneas are elliptical, so that would be kind of like more of an average or normal shape, and some people even use toric ellipses, and we know so many corneas do have toricity. But when you're using a reference sphere, it's going to really highlight changes, whether they be normal astigmatism or abnormal elevation changes like in keratoconus and other ectasias, much more obviously than when you utilize some of these other reference surfaces like ellipse or toric ellipse. So that's why we tend to use the best fit sphere as the reference surface. And we can see on the next slide here how in a spherical eye the corneal elevation can be represented color-wise. And we can see that the cornea actually in the center here is higher than the best fit sphere, so, or more anterior, so it's going to be warmer, as we can see here. And then it starts to drop off, and you see an area here where it's actually lower than the best fit sphere, which would be the blue area, and then going far out into the periphery it becomes more anterior once again. So that's typical of a normal prolate cornea, a positively aspheric cornea. If we had a truly spherical cornea, it would be an even color and it would be all green, because it would match up the best fit sphere. So what happens if we have an astigmatic surface? Well, we're going to have differences along different meridians, as we can see. You get this kind of saddle-like appearance that are separated by 90 degrees. Now, the one thing I do want to bring out here that confuses people a lot of times is on curvature maps, the steeper meridian tends to be warmer in color, and the cooler meridian is flatter in curvature. So the steeper meridian tends to be warmer colors and the flatter meridian cooler colors. But in elevation, cooler represents posterior. So it's dropping off relative, okay? So because as that curvature steepens. So you're going to get virtually an opposite effect. In the steeper meridian, it's going to be a cooler color, and in the flatter meridian, it's actually going to be a warmer color in elevation maps. So it's kind of the opposite of looking at curvature maps. You get used to that quite quickly, actually, once you start utilizing this a lot. Now, if we take a look here, we have an example of an abnormal and normal elevation. On your left, you see a normal astigmatic elevation. On the right, an abnormal keratoconic elevation, both these representative of the front surface of the cornea. And we can see this little high point, very anteriorly displaced. That's the apex of the cone. Well, the story, as this slide says, is often on the back side, as experienced by this unfortunate gentleman. But we're going to now concentrate on the part of the anatomy that we're here to talk about tonight. We'll be talking now about the cornea. So this is a representation of a keratoconic posterior surface cornea. And we can see that hot spot here that is very anteriorly displaced. And the point I want to bring out here is the fact that in virtually every case of keratoconus, and over the thousands of these maps that I've seen of keratoconic patients over the years, the posterior surface anterior maximum elevation is more anteriorly displaced than the anterior surface of the cornea. And if you think about it, that makes perfect sense, because if the back surface is more anteriorly displaced than the front surface, that localized area is going to be thinner because the back is pushed forward more than the front is. So it's going to get locally thin in that point. And of course, that's what we see in clinically significant keratoconus. And another important point, and that is what you don't see for sure can hurt you. Just like in a big iceberg, a ship is coming along, they don't really know what's going on under the surface of the water, and it's typically that's where people get in trouble. Just ask those folks who were on the Titanic. Well, in keratoconus, it's very important. Why? Because we can have situations, and we see them quite often, where the anterior surface of the cornea, both in terms of curvature and in many cases even in elevation, may be perfectly normal, but the posterior surface of the cornea is abnormal. And when we see progressive changes in keratoconus, very early in the disease, we'll actually see posterior changes occurring even before anterior changes in elevation. And this is an important factor. And in fact, it also explains why probably those folks who have made comments about true unilateral keratoconus, they would seem to think that there are more of those cases when they're doing Placido topography than those who would be making those same assessments with corneal tomography like Pentacam. Why? Because we do see cases where in one eye, clinically relevant keratoconus on the front and back surface, and in the other eye, the front surface appears to be perfectly normal, yet there are abnormalities of the back surface. So although there seem to be true cases of unilateral keratoconus, we may show you one a little bit later based on corneal tomography, they are surely less commonly found when you're doing tomography like Pentacam as opposed to measurements with Placido-based front surface topography. So here we're trying to bring out the point of where is the cone itself. And a lot of folks who look at curvature think that that inferior steep area is the apex of the cone, and by no means is that the apex of the cone. That's just the area where the cornea is curved most steeply. The elevation tells you where the apex of the cone is. And here on the anterior surface, the maximal elevation is the apex of the cone, and just behind it on the posterior surface, we can see more dramatic anterior displacement. So that will cause, of course, in the same area, a localized thinning. So you see that coincident positioning of the maximum posterior elevation, the maximum anterior surface elevation, and the thinnest point, and that is quite diagnostic of naturally occurring keratoconus. Now let's go on to talk about pachymetry, and I mentioned that with the Pentacam we're getting global pachymetry, and we do. We can get measurements of corneal thickness at any point. In fact, if you have a live image with your system, you could put your cursor anywhere and get a thickness value. And it is important to know what the minimal thickness is, which is typically represented by this little circle. And surely in cases of ectasia, we tend to have thinner than average corneal thickness at the thinnest point. However, that doesn't always tell the story, as we'll show you in a few moments. But what the system allows you to do is to evaluate the change in thickness from the thinnest point out to the peripheral cornea. And this is done through what's called Pachymetric Progression. And so we'll start with that thin point, but you'll see we'll expand out. And the computer will average the thickness along those rings, and these concentric rings go from center to periphery. And what ends up happening now is that we'll end up displaying, as we'll show you here, a key display. And this display, or the Pachymetric Progression display, shows two key findings. One's called the Corneal Thickness Spatial Profile, or CTSP, and the other, the Percentage of Increased Thickness, or PTI. Now, the corneal thickness spatial profile basically tells you the actual thickness in microns from the central portion or thinnest point in the cornea all the way out into the peripheral cornea. And we do have a statistical mean and standard deviation to create a normative range. But the percentage of thickness increase is a bit different, and it actually is more sensitive at picking up naturally occurring ectasia. And what the PTI will do is tell you the percentage of increase of thickness from that central point out to the peripheral point. And in keratoconus, we'll see it'll change from thin to much thicker at a much more rapid rate. So that red line for the patients could actually come down below the limit of normal. And we'll show you some examples now. So here we can see a blatantly abnormal keratoconic case. We can see in the CTSP even that at the thin point is outside the normal range. You can see there's a limitation of thinness outside the normal range, and then as it gets thicker it gets more normal. But look at that PTI, and it really drops down quite far below the normal range. This is obvious. It's obvious on both of the displays, the CTSP and the PTI, but let's look at something different. Here's one that's kind of interesting, because if you look at the thickness spatial profile, it's normal all the way through, from the thinnest point all the way out to the peripheral point, yet the PTI is changing at a more rapid rate than would be considered normal. Let's look at the patient's four-map refractive that corresponds to this particular Pachymetric Progression display. And you'll see that it obviously is not a normal cornea. We have an inferior steepening that we see on the curvature value, a subtly abnormal anterior displacement on the front elevation, a blatantly abnormal posterior maximal elevation corresponding in position, but yet the thickness, even at the thinnest point, actually is 523 microns, which is still normal. But the change in thickness from that point out peripherally is abnormal. That's why the PTI is abnormal. So what are some of the key things that we look at when thinking about keratoconus, for example, when we look at especially a four-map refractive? Well, first I do look at the maximum curvature, or the Kmax, which is the steepest curvature point on the front surface of the cornea. We look at the anterior corneal elevation maximum at the thinnest point. We look at the posterior elevation maximum also at the thinnest point. We also can look at these values at the cone apex as well. We look at the thin pachymetry point, both in terms of its value in microns as well as its location, meaning is it centralized or is it decentered? As we know, many cases of corneal ectasia keratoconus are decentered for their thinnest point. And very importantly, we look at the PTI, or the Pachymetric Progression Index. Sometimes also, especially in fitting certain corneal rigid lenses, I'll look at the central eccentricity value on the front surface of the cornea. And of course, especially if the cone tends to be more central in its position, we're going to get highly prolate values for the front surface eccentricity. And you'll see a couple of other factors that we'll look at coming up soon are also important in the diagnosis and monitoring and management of keratoconus and ectasia. So I'm going to just go through a quick little example of a patient here. This is one of our patients at the time we saw him, a 36-year-old male, progressive changes in vision, in quality of vision over a number of years, was unsuccessful in soft lens wear, told at an optical chain that he has a cornea problem. They weren't sure. He was referred to our group for diagnosis and management. And here you can see manifest refraction and reduction in best corrected spectacle acuities. Manual keratometry showed significant distortion, greater in the right than left. And of course, slit lamp showed certain classic signs, void stripe, Fleischer's ring, and even a paracentral scar. So of course, we're dealing with keratoconus in this particular case, but I wanted to share with you the Pentacam analysis that's very classic. We had Kmax values that were much higher than normal, as we can see 56 and 63. We had elevation values that are far outside the normative range, both on the front and on the back of the cornea, and we had very thin corneas, especially in the right, 395, 425. Anterior surface eccentricity values were very high because, as you'll see, this particular patient had fairly centralized apices of the cones. And the Scheimpflug images showed bilateral anterior stromal scars, and we'll show you that in a second. Here we can see the right eye. We can see how fairly well centered that cone is, the abnormal apex on the front surface, the more dramatic anteriorly displaced apex on the back surface, and the coincident very thin point, the thinnest point being 395 microns. And here we can see the scar on the Scheimpflug image corresponding to the central stromal scar in that right eye. And I think we're going to see the left eye coming up, also quite centralized, which, by the way, from a contact lens fitting standpoint, makes life much easier when trying to fit these patients in corneal GP rigid lenses. They tend to, of course, center over the highest point, and when they're centered, it makes optics a lot easier. So when I see this, I say thank you very much. So we could also see, by the way, the E value being very high, as we know what typical cornea is 0.4, 0.5 in that range, and here we are at 1.35. And here, once again, the Scheimpflug image showing that scar. And we could also see here in the densitometry readings, you get a real peak when we go right over that scar. So we could actually do a measurement here for quantification of that scar density. Now, we talked about some other measures that are very important in detecting keratoconus and other forms of ectasia. And there's something that we call the Bellin-Ambrosio Enhanced Ectasia Display, or the BAD display, developed by two really wonderfully bright physicians, Mike Bellin and Renato Ambrosio. Mike Bellin, I think, is practicing now in the Arizona area, and Renato is down in South America, I believe. What this particular display does, it combines elevation and pachymetry data, and it actually takes both the anterior and posterior elevation maps and creates two types of best fit spheres and compares them. It uses the conventional standard best fit sphere from central 8 millimeters of elevation data of the cornea, but creates what we call an enhanced best fit sphere using the same central 8 millimeters of cornea data, except what it does, it takes 4 millimeters around the thinnest spot on the cornea and takes that information out of the calculation. And as you'll see, what that does is it will actually enhance the appearance of ectasia by doing that. It also takes pachymetric data, the thinnest point on the cornea, the pachymetric progression, and something we now on the new form of the BAD display called the ART Max, and we'll go over that quickly in a few moments. It's a very sensitive measure for ectasia. This is the most current form of the Bellin-Ambrosio display, and we can see here talking about the front elevation all the way down here. This is the back surface corneal elevation. These here are based on the traditional best fit sphere. These analyses are based on the enhanced best fit sphere, and then this shows you the difference. If there was no significant difference between the two, it would be all green, but when you've seen these red areas, it's telling you there's a very significant difference when utilizing those two best fit spheres. And there's a bunch of different data points. I'm going to go back there for a second. Down here, these are all statistical analyses of important measures that make us concerned about ectasia and an overall judgment of whether we're dealing with ectasia. And obviously, when one sees red, that usually means we have a problem, and this is red across the whole way. There's no doubt that we're dealing with a patient with keratoconus here. So what about that best fit sphere issue and the enhanced best fit sphere? Let's take a look. So here we have a best fit standard sphere, okay? And we have a keratoconic cornea. Here we have a best fit sphere that takes away the elevation data from the central 4 millimeters around the thinnest point. So what it's going to do, it's going to create a lower, a less elevated overall best fit sphere because it's taking away that elevation data that's most anteriorly displaced. If you have a normal cornea, there's not going to be any difference, as you can see. And so what that does is just enhance the ability to see and to detect that anteriorly displaced portion. And here we can see an older version of the bad display. It didn't include things like artmax and some other data points, but I just wanted to show you, in this particular case, on the front of the cornea, comparing the standard to enhanced best fit sphere, really no big difference. But on the back of the cornea, there was a big difference. And that influences, along with pachymetric data, the overall determination of whether the software feels that ectasia is present. So we're just kind of isolating those things that we just talked about here. So what about the new generation of the Bell and Ambrosio display? One thing it does is kind of interesting, is that it includes a special button to indicate whether the patient's refractive error is hyperopic. It defaults to myopia. And the reason is that data on many patients that was accumulated for normative data showed that normal corneas, non-ectatic corneas, but normal corneas for hyperopes tended to have back surface elevation data that was more anteriorly displaced. So the normative values that we can say are normal versus abnormal are actually different for myopia versus hyperopia. So when we use the Bell and Ambrosio display, we want to figure out, are we dealing with an abnormal or normal back surface? We need to press that button on the display to say we have hyperopia because, as I said, it defaults to myopia. So that's kind of helpful because there is a difference. We could think that there's an abnormality when there's truly a normal cornea if the patient's hyperopic and we haven't indicated that or pressed that button. The artmax we talked about before, and what that is, it's a ratio. It's a ratio between the thinnest pachymetric measure and the pachymetric progression index, the maximum pachymetric progression index. So it gives a ratio value that's very, very sensitive in ectasia diagnosis. And here we can see another example of the bad software, the newer form, and there's that little button for hyperopia that you can press, and we also highlighted the artmax value. And it will also kind of give us, beyond just the artmax value, it will do an analysis of normative quantification for that artmax value in terms of whether it's normal, borderline, or abnormal based upon differentiation on standard deviation from the average. So that artmax value holds a lot of weight towards the overall value, or the overall D value or deviation value, to determine whether this software feels that there is ectasia present. So what about this case? Let's take a look at it. Well, if we just take a look at it, we see that the front surface curvature looks pretty normal, doesn't that? If we looked at that, we wouldn't think that that's abnormal. Actually, the front elevation looks pretty normal, kind of astigmatic, maybe a little bit decentered a little bit, but not that weird. but the back surface definitely looks abnormal to me. You see this little hot spot? And overall thickness of the cornea? Nope, not really too bad. But let's apply the Bell and Ambrosio, and this was done before the 3rd generation, so we're not going to have artmax here. But we can see that there is a definitive difference between the enhanced and standard best fit sphere on the back of the cornea, no significant difference on the front, and overall it did feel that we are dealing with ectasia, as I would clinically feel by just looking at the foremap, to be honest with you. And what we're dealing with here would be a case of false negative on Placido topography, but early ectasia. Meaning that if all we did was Placido topography, all we would have had was the anterior surface curvature values, which we saw were actually normal, but this is by far not a normal cornea. We can even see the PTI being outside of the normal range, as well as the posterior elevation. So both pachymetric and elevation data here indicate early ectasia. So let's start taking a look at just some examples of imaging, because we can utilize the Pentacam for imaging of the anterior segment. Now, surely those of us who have anterior segment OCTs, and we do in our practice, surely the resolution is higher and finer with anterior segment OCTs, but we get a lot of information and a lot of software applications on Pentacam that go far beyond what OCTs currently are capable of doing. So it's still nice to have imaging aspects. And here's a real interesting one. This was a case of a patient that we had who came in, who was keratoconic, and he ended up coming in wearing a hybrid lens that was adherent to the cornea and was one of the older versions of the hybrid lens with very low oxygen transmission. And his cornea was very edematous. And we can see here in the global pachymetry something very interesting. So let's blow that up a little bit. You can see that hot spot even within the thick cornea. So let's make it larger here, and we can see it better. Yes, these are thick corneal values up at the 600s and 700s. This is an edematous cornea, but we still have that hot spot of thinness. Excuse me. Its relative thinness to the rest of the cornea, because obviously 580 microns is not thin, but relative to the rest of the cornea, we can see a localized area of thinness. That's because he's keratoconic. And when the cornea resolved, all of these numbers became significantly thinner. And we can see here in the PTI being abnormal, even though the overall corneal thickness, as indicated here by the CTSP, is much thicker than normal. The change from the thinnest point to the thickest point is still quite rapid, which is classic of keratoconus. Kind of an interesting case. And here's another interesting case where we use a comparative display. We had a case here of corneal hydrops in keratoconus. Patient came in, we could see that very, very thick areas of the cornea, still some areas that didn't thicken up, but a significant thickening in this area. And then within a week or so, with treatment, we treated the patient with hypotonics as well as with, hypertonics as well as with steroid drops. Patient really started to go back to their normal thickness. And here we can see the difference where in this little area here we had over a 300 micron thinning relative to the time when Hydrops was in full bloom. Next, we're going to look at a comparative map on one of our cross-linking patients that was done over this past year. And we have a pre-treatment, we have a post-treatment, and if you look at the values, and these are axial curvature maps, you know, without looking at numbers, they look kind of the same. You said, really, I don't know if anything really happened after 6 months after cross-linking. But when you do the difference map, look at this area, significant area of corneal curvature reduction or flattening of the corneal curvature. Same patient on the next slide showing the difference in elevation on the front of the cornea. Again, when you just look at it color-wise, it doesn't look that impressive. But when you do a difference map, you can see that area of significant elevation reduction after cross-linking 6 months later. We talked before about unilateral keratoconus. Does it really exist? Well, let's look at this one in Pentacam. Is there any question that this patient's keratoconic on this particular eye and this left eye? Well, I think we'd all agree to say no. We see that very steep asymmetric curvature. We see the elevation, focal elevation anteriorly on the front, the more dramatic anterior elevation on the back of the cornea, and a localized coincident position of thin point of the cornea. But let's look at these values. You can see the K max 65.9, the Q value, which is opposite of E value, just with sign. It's equivalent to an E value of 1.25, very high. And we can see the localization of the elevation and thin point there. But let's look now at the other eye. Now, if we take a look at this eye, for the most part, we would all have to agree this looks pretty normal. The only thing that looks slightly suggestive is a slight anterior, superior versus inferior curvature difference, but it's quite minimal. And if that was the only finding and we didn't have the other eye to say, ooh, does this person have keratoconus here, I think most of us would agree that we're not dealing with an abnormality here. The elevation data is absolutely normal, and as is the global pachymetric data. Now, this would say to us we have true unilateral keratoconus as evidenced by the Pentacam. However, there are other technologies that we're looking at currently, things like high-frequency ultrasound to measure thickness of the epithelium, as well as high-resolution anterior segment OCT to measure the thickness of the epithelium on the front surface of the cornea. And there's thought that there may be changes occurring there even in advance of changes picked up on tomography with Pentacam. So this case may or may not be a true case of unilateral keratoconus. We have to see over time. Now that's a cone. This is probably the most advanced keratoconic patient I've ever managed, and I like to share that in many of our talks. This particular patient came in and just absolutely said, my doctors before want me to have a corneal transplant. I don't want a corneal transplant. I don't want to have surgery. You have to try something. And we did, and we were able to actually fit him with about an 18.5 millimeter scleral lens, and was able to get him to acuity of about 20/40 plus, and he was functioning quite well and still is to this day. It's amazing that he's still holding out. Now let's take a look at that left eye, and we can see how crazy this Pentacam looks, but look at some of these numbers. K max 103 diopters on the front surface, the steepest portion, and the thinnest part of the cornea is 93 microns. Okay, what about utilizing Pentacam this way? This to me is one of the most compelling stories I'm going to talk to you about tonight. Patient that we saw a number of months ago, 54-year-old woman, comes in for a keratoconus consultation. No big deal. She has moderately advanced keratoconus, and she wanted to have a better contact lens fit, and that was fine and dandy. But the story was that she was brought in by her younger son, who I believe at that time was either 28 or 29 years old. And we said to him, you know, how are your eyes? My eyes are great. I see perfectly. I said, when was your last eye exam? He goes, I don't know. My eyes are perfect. I see 20/20. I can see further than anybody I know. So I said, could you humor us and just let us do this one test with your eye? Because mom's got this particular condition. We know there are strong hereditary components to this condition. And he said, okay, as long as we didn't charge him. And I said, no, this one's on me. So what do you think happened? Here we go. There he is. There's the son. Okay, he was age 30 when I was off by a couple of years. I couldn't recall that. He had uncorrected acuities of 20/20 in each eye, and here's an example of his left eye. And we can see anterior elevation, subtle anomaly, definitive posterior surface elevation anomaly. We can see a decentration of the thin point, and it is relatively thin. Let's apply a Bell and Ambrosio analysis to this young man, and we can see a definitive difference on enhanced versus standard best fit sphere on the back surface. We can see a definitive abnormality of PTI, even though his overall corneal thickness is within the normal range. So, does this young man have keratoconus? Absolutely. What did we suggest for him? Cross-linking based on his age, based upon his mother's condition and her severity of keratoconus. This was sort of a no-brainer. Very important today to manage keratoconus in different ways than we did 10 years ago, because now we can control, in many cases, progression. So early diagnosis is critical. Examination of family members, especially those at risk based upon age, is also critical. Another couple of interesting things to share with you. And here is a story about PMD, pellucid marginal degeneration, a condition that I think is overdiagnosed on Placido topography constantly all the time. Most of the cases are truly keratoconus and they're pseudo-PMD. How do we know? Because true PMD has inferior thinning, right? So what do we know about pellucid? It's a corneal condition that has basically a band of thinning anywhere from 1 to 2 millimeters in from the inferior limbus. So we have to look at the global pachymetry map to really have a good idea of if we're truly dealing with true PMD or are we dealing with perhaps a form of keratoconus with an atypical axial curvature map. So let's look at that. Here's a true case of PMD, as we can see that area of inferior thinning. And you can see on the cross-section of the Scheimpflug image, that's quite classic. But if we look at another case, this is one of our own patients here. If you just look at the axial map, it just screams out PMD, and that's what people call pellucid all the time, and they think they're fitting pellucid. But let's look at the elevation maps, classically keratoconic, and look at the thickness map, the global pachymetry map. The thin point is not down here. The thin point is more centralized, more coincident with the elevation points. So this is truly a regular case of keratoconus, different than true PMD. So very careful slit lamp examination. It will help us understand that if you can really determine where that thin point is with an optic section, but much easier is to look at the global pachymetry map on Pentacam. So here are some cataract applications. These are some glaucoma applications. We're going to get to cataracts after. Let's just use this case that we had. We had a 79-year-old man, early cataract formation, a family history of glaucoma, both his mother and sister, hyperopic refractive error, low astigmatism, and just on slit lamp, we had an estimate of nasal and temporal angles at about +1, so narrow appearing angles. IOPs were mildly elevated, but the optic nerves were absolutely normal in size and rim appearance. Cup to disc ratio was estimated at 0.25. We did a retinal nerve fiber layer assessment. It was perfectly normal as well. Well, when we do glaucoma screening, what can we use Pentacam for? Well, of course, we can use the pachymetry data to create IOP-corrected numbers based upon corneal thickness, or at least give us an idea if we should look at our pressures differently if we're dealing with a thin cornea, as we all know. Very powerful is the ability through the Scheimpflug Imaging to evaluate the anterior chamber. We can look at the angle, 360 degrees. We can look at iris contour, the angle approach, whether there's a plateau configuration, whether there's peripheral anterior synechia or recession. Iridotomies show up on this as well, and whether they're patented through and through as well. And we can get actual quantified measures of anterior chamber depth and volume, as well as the angles. And here are some key factors. Now, we don't tend to really put too much weight on getting a corrected IOP. We just know that if we're dealing with thinner than average corneas, we have to consider that when we're looking at IOP values, as most of us do. Here, more quantified and important to us are the angle measures in degrees, the anterior chamber depth in millimeters, and the anterior chamber volume in cubic millimeters. And this can be looked at in Scheimpflug, as we see, and here's a case of a relatively narrow angle, as we can see, with mild anterior bowing of the iris. And we can see these angles at about 24 degrees, kind of on the narrower side. This a deeper, much deeper anterior chamber and a deeper angle, but you may get a feeling of this area showing a slight plateau configuration, just to show you that you can look at the iris contour in that way. Now, we look at some of these numbers based upon quantifiable data, and this was outcomes from a study done in 2009 where they took a significant number of patients and performed both Pentacam and gonioscopy on these patients. And experts who were expert observers doing contact gonioscopy decided which of those patients had what they felt were occludable angles on gonioscopy, and then they looked at the data of those patients on Pentacam. And that's where they got some of these numbers, where they said the average angle, which was measured between 3 and 9 o'clock in these patients who seemed to be occludable on gonioscopy, was an average of 24 degrees plus or minus 5. The average anterior chamber depth, 1.9 millimeters, again plus or minus 0.3 millimeters, and that was measured from the corneal endothelium to the anterior lens surface, and these were all phakic eyes. So these numbers become important. So when we start looking clinically, when I start seeing patients whose average anterior chamber angle is in the low 20s, and more significantly when it's below 20, I get concerned. If the anterior chamber depth is below 2, I start to get concerned. And of course, the lower, the more significant. So we can see in the patient that we talked about before that the angles are relatively narrow. The average angle at 23 degrees with anterior bowing of that iris. We can see the anterior chamber depth below 2, 1.36. That's quite a shallow chamber. And the anterior chamber volume, when that's below 100, I do get concerned. See, this is at 67. So this patient we definitely recommended and did have performed LPIs. And patient's still doing well to this day. And if we look at the indices values that we talked about at the beginning of the talk, we can again look at some of these key findings. So it's easy to call this up in a patient. If you take a look here, the anterior chamber angle, again, 14 degrees, very, very narrow angle. Anterior chamber depth, very, very low, 1.6. And anterior chamber volume at 64, quite reduced. Obviously, this is a patient, as we can see, is well outside the normal values. We can see those lines in the abnormal area. Now, one cool thing you can do now with some of the newer software is you can have a view of all of the Scheimpflug images 360 degrees around, and you can take a kind of a gestalt view and look for the narrowest of all the angles. Because sometimes the average might come out pretty good, but then there are certain sectors that are significantly more narrow. Also, you can do differential comparative maps, and this one being the anterior chamber depth pre and post LPI, showing a deepening of that anterior chamber depth. Or you can actually do comparatives of two Scheimpflug images that are displayed one on top of the other, and we can see how that iris has kind of dropped down post-surgically. Kind of neat thing to see. And that's all with some of the newer software available on Pentacam. Cataract applications will start going a little faster at this particular point. Well, there's a number of ways to look at it. We can look at the densitometry, as I mentioned before. We can get kind of quantified measures that we can watch for change over time as a cataract does develop, and we can use that educationally for our patients, obviously. An important thing here is we can see some of that densitometry causing these little peaks here in this nuclear sclerotic cataract right here. Now, we don't have time to go through all of the details tonight, but there are a variety of displays, this being the cataract preoperative display, that allows you to help make a decision on whether or not a patient would be a good candidate for various types of IOLs, whether they be aspheric, multifocal, toric, so on and so forth. And there's various ways and steps suggested in the software on how to best do that. Of course, in the instance in which anterior chamber phakic IOLs are considered, specific measurements can be taken and measured with the Pentacam as well to pre-plan for that type of surgery. Contact lens fitting, another thing that you might want to consider. There's software in the Pentacam, and you can do simulated contact lens fitting typically for corneal rigid lenses. And we can see here values of corneal asphericity in different areas. We can see simulated fluorescein patterns that can be created with different parameters of lenses. There's a whole host of proprietary lens designs that we can quote-unquote virtually fit to the eye, or you can actually use the customized section and design your own lenses, and without putting diagnostics on the eyes, have simulated fluorescein patterns created, and we can see where apical clearance and such can occur, or bearing, depending upon the case. and you can make the modifications. And one of the things that we can do in that contact lens software is, especially in toric corneas, to see the difference between toric back surfaces on GP lenses and spherical back surfaces and how they would fit. Well, let's talk just briefly about coding and how we build for this particular instrument. Well, surely there is topography. And if we have the right diagnostic code that matches with topography, we can submit in for reimbursement. Pachymetry, that's questionable because the pachymetry code 76514 actually is for ultrasonic pachymetry, and this is optical pachymetry. So you might have to use 92499 and do a descriptor. Anterior segment imaging, I think that's valid. 92285, and again, there are certain criterion and certain diagnoses that your carriers will reimburse you for that code. You have to meet the criterion of helping in the diagnosis and or helping in the management of the condition for change over time, and I think in many of these cases we can justify that. But we often utilize our Pentacam as components of diagnostic evaluations for contact lens fitting. We utilize them to monitor patients who've had refractive surgery to make sure that they're staying stable, and of course pre-refractive surgery. And those we actually do charge patients out of pocket for because there would be no medical necessity that would be covered under any specific diagnostic code for those particular circumstances. So let's see. Interesting. That kind of brings us to the end of our talk tonight. We actually did pretty well. I think we only went a couple of minutes over. And I just wanted to give everybody kind of a quick taste of some of the things that Pentacam can do, but I can tell you in all honesty, we truly didn't scratch the surface yet. There's so much more that this instrument can do, and with software that keeps expanding, it's really been such an honor to have used this instrument over the past years, and really is something that we find that we really can't do without. Whenever there might be a circumstance where we might need servicing for this instrument or something like that, and I don't have the ability to use it for a day or two, I feel like somebody's just tied at least one of my hands behind the back. So I hope that you enjoyed this evening, and I'll be available, Craig, to answer any questions.
Thank you very much, Dr. Barry Eiden, for the exceptional educational webinar. Ladies and gentlemen, thank you very much for attending this webinar this evening. We really appreciate your time. This webinar has been recorded and will be posted on the Oculus website very soon. Thank you, Dr. Barry Eiden, for your time today and educating us all. And,
my pleasure.
Thank you very much. We hope in the near future you will be able to do a few more webinars for us.
I'm there.